my disclosures are shown here. So when we think of the global population, we recognize quickly that the majority of the world's population would characterize itself as having various degrees of richly pigmented skin and belong to the various non-white racial ethnic populations. And here in the United States, the proportion of the population that would self-identify as the various non-white racial ethnic groups is a rapidly growing segment of the US population. In fact, by the year 2044, it's projected that more than half of the United States will belong to these non-white demographic groups. So it becomes increasingly important to understand the overlap between structural and functional variations, cultural skin and hair care practices, as well as cultural variations in standards of beauty and skin health as they relate to variations in the epidemiology, the clinical presentation, and the overall quality of life impact of dermatologic disorders. So with respect to psoriasis, we do see differences in the epidemiology across different populations, as well as some nuances in the clinical presentation, differences in quality of life impact, with some studies showing greater degree of quality of life impact in populations with skin of color, and we'll talk about that, and some unique treatment considerations in some specific scenarios of patient populations. So starting with epidemiology, data from the United States has shown that psoriasis is by no means rare among populations with skin of color or non-white racial ethnic populations. In fact, in this study, psoriasis prevalence, while being highest among whites or Caucasians, it was estimated at 1.9% in African Americans, 1.6% in Hispanic or Latino populations, and 1.4% in other racial ethnic groups. So by no means rare, and in contrast to some of the older literature, which suggested much lower prevalence. And underdiagnosis does play a role in some of our epidemiologic data and perceptions of this being less common. Now, when it comes to the clinical presentation of psoriasis in our populations with skin of color, in some instances, the classic salmon pink, well-demarcated plaques with micaceous scale. We may see that just as in other groups without any difficulty in making the diagnosis. However, in other skin types and individuals, we might see a variation of clinical presentation, especially with respect to color. So instead of the various shades of red, we might see a violaceous hue in skin types, in very richly pigmented skin types, such as in this example. Another example of this very violaceous, clearly almost purple here, hue in this plaque on an African American individual with psoriasis. Because of this violaceous hue, of course, this brings a challenge for the clinician in terms of differentiating this from other papillosquamous disorders that are violaceous in hue, most notably lichen planus. We might see a range of other colors with respect to the spectrum of psoriasis and skin of color, including a sort of reddish brown hue, as in this example, or in this example in an Asian patient, a little less dramatic as far as the brown component, but you can still see some mixture of red and brown in some of these plaques. We may see more of a grayish appearance where most of the erythema is masked by the background melanin, and we just see the gray appearance of the scale, as in this example, and one has to look very carefully to see hints of violet and red within these plaques. And it seems that I'm having trouble advancing the slide for some reason. So I'm just going to try and get that going. Here we are. All right, another example. This is sort of a gray to violaceous hue of this plaque in an individual of African descent with psoriasis. Another example, gray to violaceous hue of the sharply demarcated scaly plaques. And so just emphasizing how the erythema may be clearly different across the spectrum of of patients with skin of color. And this has implications for the accuracy of diagnosis, accuracy of assessment of severity in the clinical setting, as well as in the clinical trial setting. So when it comes to other data that looks at differences in the morphology and subtypes of psoriasis across different racial ethnic populations, there are limited data, but this is one cross-sectional study from UCSF, San Francisco, that looked at population variations in subtype and found that Asian and Hispanic or Latino populations had a higher odds of having pustular psoriasis, at least in their cohort at UCSF, compared to whites or Caucasians. And Asian patients, again, in this cohort had a higher frequency of erythrodermic psoriasis. And now we have to take these data like this and with all the caveats and limitations. This is just a single center, and the methodology is limited in that this was cross-sectional, patient-reported and physician-reviewed survey data, but it just tells us that there may be differences. It gives us a signal that there may be differences in the common subtypes and morphologies and clinical presentations of psoriasis across the spectrum of diverse patient populations. Jim Kruger and colleagues have including Korean colleagues such as Liu et al. Have described a small plaque psoriasis that resembles guttate in morphology, but is more chronic in its sort of clinical behavior, and seems to be a predominant subtype in Korean patient populations as well as other East Asian populations. And Kruger and colleagues have looked at this small plaque psoriasis and among other findings have found that compared with Western large plaque psoriasis, Asian small plaque psoriasis revealed limited psoriasis spreading, but IL-17A and IL-17 regulated pro-inflammatory cytokines were highly expressed. Now, one thing that is a clear feature of psoriasis across the spectrum of patients with skin of color is the tendency to develop post-inflammatory pigment alteration in the form of hyperpigmentation or hypopigmentation after an active lesion resolves. And some interesting work from Jim Kruger and Seth Orlow and other colleagues have shown a link between the cytokines that we are familiar with in the pathogenesis of psoriasis and alterations in melanogenesis. So specifically, IL-17 and TNF-alpha were shown to have alterations in melanocyte number and pigmentation signaling, and this was reversible with the use of antagonists to these cytokines. Now, what about quality of life? Now, when we look at various available data that explore quality of life differences across populations, we see studies like this. This is just a survey from the NPF, National Psoriasis Foundation, that found a greater psychosocial impact of psoriasis in African Americans compared to Caucasians. Subsequently, we did a retrospective study, a post hoc analysis of phase 4 data of etanercept in the treatment of psoriasis. And while we did not find any differences in safety and efficacy with this treatment, interestingly, we did find that there was a higher quality of life impact among Asians and African Americans compared to whites or Caucasians in this study. More recently, a study done in collaboration with Junko Takeshita from University of Pennsylvania, as well as other colleagues and folks from Janssen, looking at the SOLAR registry, cross-sectional analysis of DLQI scores among North American patients enrolled in this registry. This involved over 10,000 patients, and what we found was that there were statistically significant differences in DLQI scores between the racial ethnic populations. Specifically, Black, Asian, and Hispanic or Latino patients reported greater impact of psoriasis in health-related quality of life scores as measured by the DLQI compared to white patients. And this persisted even after controlling for potential confounders like disease severity. And very recently, also published this year with Jerry Bagel and colleagues, looking at another registry, which involved patients who were treated with biologic therapy and followed up 6 months later. And in this registry, after 6 months of biologic treatment, Asians had a 33% lower odds of achieving a DLQI score of 0 or 1 in both the unadjusted and adjusted models looking at this. So this persisted even after adjusting for potential confounders. So we're seeing multiple studies that are pointing to a greater quality of life impact in patient populations with skin of color. The reasons for this are still not clear and deserve further study. But one reason may be the additional impact of pigmentary sequelae, as well as cultural perceptions of the disease. There might be some cultural factors that influence the overall burden, but this is definitely something that warrants further study. With respect to the pigmentary alteration, this has implications for what our desired therapeutic endpoint is. So it's more than just clearing of the psoriatic plaques in real-world practice. It's also resolution of the pigmentary sequelae that's important to the patient. And so our timeline to get to a satisfactory outcome for our patient is longer. So it lags weeks to months after the clearance of the psoriatic plaques. Anecdotally, when we use highly efficacious therapies like biologics, we do tend to see not only improvement of the active psoriatic lesions, but over time, resolution of the pigmentary sequelae as we control the condition longitudinally and prevent new plaques from developing. The pre-existing post-inflammatory areas of pigment alteration will be allowed to resolve. And so we tend to see great outcomes when we really manage the disease effectively over time, as we do with biologics. However, when we look at our data available for potential differences in efficacy and safety across different racial ethnic groups, we are hampered by the demographics within our studies that overwhelmingly have white or Caucasian individuals and have much less representation of non-white racial ethnic populations, especially in the Black patient population. Consistently across psoriasis studies, we're seeing very low representation. This is a recent systematic review of the published studies of biologic therapies in psoriasis, and I recommend looking at this to know what our current knowledge is of potential differences. But these are again limited by small sample sizes and post hoc analyses, and so difficult to interpret whether there are any real differences between different populations with respect to efficacy. So the direction where we're going is now designing studies that from the outset include a representative sample of the demographics that we treat today, particularly in the United States. And so a study like this, which is one that is actively enrolling right now, it's called the VISIBLE study, a study of guselkumab that includes patients from Fitzpatrick skin types 1 to 6, includes self-identified racial ethnic populations in each of the categories with strong numbers in the non-white racial ethnic groups, and we look forward to seeing data from this. Another exciting thing about a study like this is that it includes novel endpoints that are particularly relevant to patients with skin of color, including measuring pigmentation objectively and seeing what the impact of treating with biologics is, not just on the psoriatic plaques, but what happens to the pigmentary changes over time. So we look forward to seeing results from that. So with that, I'm going to close here and just show a couple of recent references that you can turn to for more information on this subject. And I'd be happy to take any questions during the Q&A and discussion period. Thank you so much.
Thank you very much. Would anyone, because I think Professor Andrew has to leave, so if anybody has questions right now, we start by questions for him. Can I ask you a question? How do you deal with the hyper and hypopigmentation? As you know, I come from Egypt and we have different coloring. And maybe we were discussing this in the group that the color is not always black. Some are just darker. I mean, the Fitzpatrick doesn't do it justice, but we get a lot of hyper and hypopigmentation, and it seems it's related to the ethnic origin, not only to the color of the skin. So how can we handle that from your point of view?
Yeah, it's a great question, and I think that's really a unifying concept across this very diverse spectrum of patient populations that would be characterized as having skin of color. To your point, it's not just the color of the skin that might predict the post-inflammatory hyperpigmentation. We may see individuals of intermediate complexion of pigmentation and still develop very long-lasting and significant post-inflammatory hyperpigmentation. In terms of how I manage it, of course, the number one strategy is to control the psoriasis itself. But while doing so, for areas that have resolved with hyperpigmentation, I will use topical bleaching agents if needed, including the triple combination modified Kligman-Willis formula of hydroquinone 4%, tretinoin, and fluocinolone. I will also use topical azelaic acid 15% in a foam vehicle, which is easy to spread over a larger area and lower risk of irritation. So I'll do that in selective zones and highly visible areas that are important to the patient to try to speed up resolution. Topical retinoids as well, another potentially useful strategy for those areas of hyperpigmentation. And of course, we know that there's also some benefit of the retinoids with the psoriasis itself. So these are some of the approaches I would use.
What about the other way around, the hypopigmentation, which is sometimes worse? What do we do with it? And they don't respond to the traditional therapies that we usually use in cases of hypopigmentation.
Yes, indeed. So the hypopigmentation is no doubt a challenge. And depending on the patient, depending on the distribution and anatomic location, I might use excimer laser for localized areas that are of great concern to the patient, highly visible areas, or if it's more widespread, using narrowband UVB phototherapy. Mm-hmm.
We are now getting a question on the chat. What about comorbid disease in the skin of color patients?
Great question about comorbidities in skin of color patients. There are some data that show higher degrees of cardiovascular and metabolic comorbidities in our patients of African descent, Black or self-identified Black or African American. But we certainly need more work to better understand those differences.
Any other questions from? Yes, go ahead.
Can I ask one question?
Yes.
I'm Jules van der Reek from the Netherlands. I had a question on the difference between people from African American people and people from Africa, because we do not know a lot about the prevalence in Africa, but it seems like the psoriasis prevalence is much lower than is seen in patients from with an African American background. I was wondering if we should focus more on that and learn lessons on how can we explain that difference.
Yeah, thank you for your great question. Certainly the published epidemiologic data would suggest lower prevalence of psoriasis in West Africa compared to East Africa, and lower rates in the African continent compared to what we've reported in the United States. But I think that we have to take it in the context of very limited data and varying methodologies, and that there certainly may be underreporting of psoriasis in the African continent. So anecdotally, for example, when I collaborated with some Ghanaian dermatologists on an atlas, and recently that has been published. And for example, the psoriasis section of that atlas, there was no problem getting all sorts of images to choose from my dermatology colleagues in Ghana. And from discussion with them, psoriasis is not a rare condition for them either, although the reported prevalence would suggest it's quite low. So I think we need better data to truly understand, but I think that this is clearly a global disease that affects all patient populations. And while there might be differences in prevalence, I don't see it as being rare on the African continent.
Do you think the worst quality of life is related to maybe less access to therapies because they do not tend to get their medications in a timely manner, and maybe their disease progresses faster? Or it might be just, as you said in your talk, other factors related. We are not sure why the DLQI is lower in patients or in individuals with colored skin. What do you think?
Yeah, so why would the quality of life impact be worse in populations with skin of color? It's, one would hypothesize, okay, to your point, maybe there are delays in diagnosis, maybe it's diagnosed at a greater severity, but it turns out even when we control for body surface area and other measures of severity, even when we control for socioeconomic factors, the DLQI differences persist. So it suggests that there may be some other reasons why it might have more of a burden. And I would hypothesize that probably the long-lasting pigmentary alterations contribute to the overall quality of life impact.
Yes, go ahead. Thank you.
Andrew, can you comment on the HIV-induced psoriasis in Africa?
Sure, thank you. Absolutely. So that is indeed in many populations where HIV is highly prevalent, that presentation of psoriasis is particularly common. Beyond stating the obvious that yes, HIV-associated psoriasis is going to be common in some populations, such as in South Africa and many other countries that have a high HIV prevalence. Beyond that, I don't have any other comments to it, other than it being, as you know, tends to present more severely.
Thank you. What about the quality of life in this population of skin of color, but in other diseases not connected with the skin, diabetes, cardiovascular diseases, because maybe the feeling of getting a disease is different in different cultures? Thank you.
Yeah, it's more stigma.
Yeah, thank you. Yeah, and I agree that there may be variations in cultural perceptions of disease, and including dermatologic diseases, and that in turn can contribute to the quality of life impact of having a disease like psoriasis. So what's the cultural stigma of having scaly plaques on the skin or the scalp? There may be variations culturally on how one's community interprets that, perceives that, and deals with that, and that in turn can certainly have impacts on the quality.
Has any study compared men with women, or it's just in general all skin of color patients had this problem? Because I think women in the cultures will be worse than men, probably.
Yeah, it's a great question. No, I'm not aware of any gender differences that have been identified yet, but that would be a great question to look at in a subsequent study. Because I agree with you, especially anecdotally, with respect to, let's take one group like like women of African descent with scalp involvement in particular. I see that as a particular presentation of psoriasis that can have a tremendously stigmatizing effect, and in turn impact quality of life adversely.
Any other questions? Thank you so much, Dr. Andrew, for joining us today. It was a pleasure. Thank you very much.
Thank you.